Hello, hello everyone. Welcome to Saliva Cast, where we bridge the gap between salivary science and clinical dentistry. I am your host, Dr. Deborah Heller, and today we're diving into a topic that affects a significant portion of our patients: medication-induced dry mouth. This is crucial because the chances are that your patient is taking one or more xerostomach medications. Current data shows us that more than 42% of all medications list dry mouth as a side effect. In most cases of dry mouth, medications are a leading cause of xerostomia and also may be a cause of decreased salivary flow, like we'll see today. So, as dentists, how do we identify, assess, and manage this in our clinical practice? That's exactly what I want to show you today at SalivaCast. Let's start by listing the main categories of drugs that can affect salivary flow. They fall into three major groups. The first, drugs that directly damage salivary glands. Here we have the antineoplastic agents used in chemotherapy, for instance. So these drugs will damage the salivary gland. Then we have two other categories. The second is drugs with anticholinergic activities. These block salivary gland stimulation, reducing saliva production. Example of these drugs, pay attention because your patient may be using them, are, for example, anti-reflux agents, tricyclic antidepressants, opioids, antihistamines, for instance, bupropion used for depression and smoking cessation, benzodiazepines, and so many others. So you want to be attentive for this. And then there is a third group of drugs. And these drugs, they act on the sympathetic symptoms. So they affect not simply the salivary gland flow production, so saliva production, but they alter saliva characteristics. So these are, for instance, antihypertensive medications such as beta blockers, and our patients may be using these drugs as you know it. So this is very important first to understand. Is this drug, is this medication really damaging the salivary gland? Yes or no? And how is it impacting saliva? Is it diminishing saliva flow or is it altering salivary components? And then we have also, of course, diuretics, right? So drugs that cause fluid depletion, reducing saliva. So why is it that I decided to bring this important topic for saliva caps? Because one of the most common misconceptions is that medication-induced dry mouth always leads to significant oral health problems. However, here's what I really want you to know. Most drugs that cause xerostomia do not permanently damage the salivary gland. Drug-induced xerostomia is temporary. It lasts as long as the drug is in effect. Taste stimulation, for instance, eating, drinking, or chewing, non-sugar-free gum can overcome this inhibition of saliva production. And at normal therapeutic doses, most medications won't cause noticeable dry mouth unless, pay attention to this, unless there is pre-existing glandular damage. This is something I really want you to keep in mind. As dentists, we need practical strategies to evaluate and to manage medication-induced dry mouth in our daily practice. Ask the right questions to your patients. Does the patient frequently complain of dry mouth? Include the xerostomia inventory in your daily routine. Is this patient taking a xerostomic medication? Do they wake up with dry mouth? You can also use objective assessments in your daily clinical practice. You can measure saliva flow rate. You can do this both at rest, so unstimulated and stimulated saliva flow rate. You can also do a clinical exam to assess the clinical oral dryness, so signs of oral dryness. And it is very important, dentists, that we differentiate between uh, medication-induced dry mouth or medication-induced xerostomia and true salivary gland dysfunction. This is very important because this medication-induced xerostomia is usually reversible, while true salivary gland hypofunction, okay, and we can easily differentiate this in clinical practice with the right salivary test. It's most commonly linked to disease, to radiation therapy, or to autoimmune disorders such as Sjogren's syndrome. So, how to manage this? Now that we already know how to diagnose it, we know the importance of differentiating this. Is this xerostomia associated with salivary gland hypofunction? Yes or no? So, which management strategies can we use? Well, gum chewing has been proven to increase salivary flow in patients with medication-induced dry mouth. So this is a great ally you can have. Uh, Nowadays, every country in the world sells sugar-free gums. Many of these sugar-free gums are already tailored for the patient with dry mouth. Many of these gums have xylitol, for example, which is also a great ally to increase saliva flow. Parasympathomimetic medications such as pilocarpine may be helpful in selected cases. I always advise the dentist to speak with the other health professionals, speak with the medical professional that prescribed that this xerostomic drug. Talk about the dose with them. Why did they prescribe this dose? Ask them if they think it may be helpful and bring them studies that back this up of using different stimulus to saliva flow rate. So we never do this alone. We see the patient as a whole, right? And saliva diagnostics really brings this connection. Saliva is the mirror of the body. So once you start doing saliva testing in your clinical practice, you'll see that you are really bringing more to your patient, and you see that you interact more and more with other health professionals. And then we also have saliva substitute that can provide lubrication for some symptomatic relief. But what I really want you, dentists, to take away from today's saliva gas is that medication-induced dry mouth is common, but not always clinically significant, okay? Most xerostomach medications do not cause permanent gland damage. The inhibitory effect on saliva of these medications can be reduced with taste stimulations. Patients rarely report dryness unless multiple medications are involved or they have pre-existing gland dysfunction. This is something that I really encourage you to investigate further. Is this dry mouth simply being caused by this medication, or is there something else here as well? Why is it that I encourage you to make this distinction? Because in order to truly treat this patient, you need to find the true cause. And for our patient to come to the clinic and complain of dry mouth, it means that they already have 50% less saliva production. So this truly means that your patient is at higher risk of disease and of diminished quality of life. A patient with 50% less saliva is at higher risk of cavities, is at higher risk of halitosis, of bad breath, is at higher risk of dental erosion, of dental corrosion, is at higher risk of having failed restorative treatment, for instance, is at higher risk of gingival inflammation, periodontal disease, is at higher risk of fungal infection, and so many other diseases in the oral cavity. So you want to know if this is the case of your patient because you want to manage their dry mouth. Either you manage hyposalivation when there is a salivary gland dysfunction associated with this xerostomia, with this dry mouth feeling, or you focus on managing simply the dry mouth feeling. So assessing medication-induced xerostomia requires both subjective, and this is where the patient feedback is very important, and objective salivary flow measurements. This is very important. Which tools do we have for subjective assessment? We have the xerostomia inventory, X1, that is ready to be used in clinical practice. 11 questions, you make it very easy to the patient. It takes less than 1 minute. You add this to your patient's interview or to your medical history form. And then you ask them if the patient is really feeling the dry mouth, the subjective feeling of dry mouth, or what we call it xerostomia. And we also have objective measurements. These objective measurements, they start with a very simple oral dryness clinical exam, the clinical oral dryness exam, or CODS. You do it with your intraoral mirror. It's very easy, also takes less than a minute. And you also measure saliva flow rate, for instance. So you combine saliva flow rate measurements with viscoelasticity of saliva, spin Barkite, with salivary pH. And you do this in your clinical practice, in your daily routine. And you do this in order to have a more efficient diagnosis of your patient, in order to really individualize your treatment to act much better, way better in prevention, because you're acting in prevention and predicting. With salivary tests incorporated to clinical practice, you'll be able to predict your patient's risk of having oral diseases, and many times this will be the first sign of a systemic condition that your patient may have and do not know about it yet. So dentist, the patient is taking medications. Almost half of all medications cause dry mouth. you need to know about this. If you want a medication list, feel free to reach out to me. My email is very easy. Deborah, Debora, Deborah at salivapro.com. Say, I listen to SalivaCast. I want a list of all the stomach medication. I send straight to your email. And about the management. The management of dry mouth induced by medication should focus on symptom relief and salivary stimulation. This will be key for your clinical success, and this will be key for keeping your patient's quality of life. That is, I would love for you to join this discussion. I would love to hear from you. How do you access and manage dry mouth in your practice? I also invite you to share this saliva cast with your colleagues, and let's discuss together how to add saliva diagnostics to our daily clinical practice. As always, I invite you to join my YouTube channel, Deborah Heller on YouTube, also to save saliva cast here on your favorite podcast streamer. So make sure you favorite and also like it. Give us feedback. What are you enjoying about Saliva Cast? What do you want to see in here? I am here for you. I am here to bridge this gap. I am here to truly connect the good science of saliva to the good clinical practice, making it a great and successful clinical practice for you and helping you bring more health to your patients. Thank you, dentists, so much for tuning into SalivaCast, and I will see you at our next episodes. Thank you so much.